everyone. I'm Zainul Abidin Assad, Assistant Professor of Medicine at University of Oklahoma in Oklahoma City. I am excited to share this AHA Early Career blog with Dr. Parkash today. Dr. Parkash is a prominent electrophysiologist and the principal investigator of the recently published RAFT-AF trial. Dr. Parkash obtained her medical degree in 1996 from Dalhousie University. She completed a residency in internal medicine and cardiology in Ottawa from 1996 to 2002, followed by a fellowship in clinical cardiac electrophysiology at the Brigham and Women's Hospital from 2002 to 2004. She obtained a Master's of Science in Epidemiology from the Harvard School of Public Health in 2004. She is currently a professor of medicine at Dalhousie University from 2004 until present. She has two major areas of research: atrial fibrillation and cardiac implantable electronic devices. Currently, Dr. Parkash is involved in a number of clinical trial initiatives in atrial fibrillation focused on mechanisms of disease and management strategies. She continues to investigate prevention of recurrent atrial fibrillation in patients with a high symptom burden to prevent future cardiovascular events and improve quality of life. Dr. Parkash is the past chair of the Canadian Heart Rhythm Society Device Committee and has been the lead investigator in initiatives to improve outcomes in patients with cardiac implantable devices. Welcome, Dr. Parkash. Very excited to have you here.
Thank you very much.
So, Dr. Parkash, everyone is talking about the recently published RAFT-AF trial. My first question for you is, could you give us a context or background of this very important clinical trial?
Yes, absolutely. The concept of rhythm and rate control in atrial fibrillation is not new. We have been talking about this issue for decades now, and as many of you may recall, the real pivotal study that is driving how we practice treating our patients with atrial fibrillation today was the AFFIRM study. There were a number of other trials that looked at rhythm and rate control around the early 2000s and late 1990s to look at this issue, and all of them concluded that there is no benefit to rhythm control and maintenance of sinus rhythm in a randomized trial strategy in terms of affecting actual cardiovascular outcomes and mortality. And so even to this day, we practice that really rhythm control is for improvement of quality of life rather than reduction of cardiovascular events. Now, we have had some recent data that changes that, and of course, that was the rationale behind the RAFT-AF study. So one of the other things that we need to remember is that rhythm control in those older trials was primarily, of course, with the use of antiarrhythmic drugs. And now we, of course, have catheter ablation, and catheter ablation has been shown to be superior to antiarrhythmic drugs in maintenance of atrial fibrillation. So that when you look at the actual percentage of sinus rhythm within, let's take the AFFIRM study, which was the largest, it was 65% of patients who, if not lower, actually around 50% of patients that actually maintain sinus rhythm. So, with catheter ablation, we posited that we could get a better reduction in atrial fibrillation using that strategy and compared that to rate control. Heart failure patients are a major source of comorbidity for patients, major source of cardiovascular events. And so we chose to do this study in the heart failure population for that reason.
Well, thank you for sharing that background that set the stage for this trial. So what was the research question that this trial addressed?
Right, so the study was aimed at looking at whether catheter-based AF rhythm control, as compared with rate control in patients with atrial fibrillation and heart failure, reduced the primary outcome of all-cause mortality and heart failure events in patients with both an ejection fraction that was preserved or reduced.
Okay. And could you tell us about the design of this trial?
Yes, so this was a multi-center randomized controlled trial that was parallel in terms of its enrollment. Its study was a probe design, which stands for a prospective randomized open-blinded endpoint design. So the endpoint was blinded in terms of its adjudication, but the trial, of course, was open in that we couldn't blind patients or operators or investigators as to which arm the patient was in. Patients were eligible if they fit the inclusion criteria, which we can review, to be assigned in a one-to-one fashion to ablation-based rhythm control versus rate control. Rate control could include AV node ablation and pacing strategy or use of medications. They were stratified by center, ejection fraction, broken down by less than or equal to 45% and greater than 45%, and type of atrial fibrillation.
Okay. And how many patients participated in this trial, and what were their major characteristics?
Yeah, so the study included 412 patients at the final analysis. The main characteristics, there's 411 patients, I'm sorry. The main characteristics that we should talk about are the mean age, which wasn't very old, but certainly older than most ablation trials that we look at for atrial fibrillation. So the mean age in the trial was 68 in the rate control and 66 in the ablation-based rhythm control group. We had about 25% women participate in the trial. Again, a little lower than we would like, but not super low. The BMI was 31. Most of the patients were non-ischemic in terms of their underlying heart disease. We had about a third of patients who had ischemic heart disease. All of the patients were class 2 or 3 by design. That was one of the inclusion criteria. 34% of patients had some type of cardiac implantable electrical device. 13% of these were pacemakers. The remainder were ICDs. We had some CRT patients included, and of course some pacemakers. The median NT-proBNP for entry into the study, again by design, you had to have a median value was over 1,000. It was 1,583 picograms per milliliter, so very high NT-proBNP. Patients were well treated with usual heart failure medications based on current guidelines. The left atria were mildly enlarged. The mean left atrial size was 46 millimeters. And when you look at the ejection fractions, when you look in the stratified groups, for greater than 45%, the ejection fraction was quite normal. It was 59% as a mean. And then for the lower ejection fraction group, it was 41%.
Okay. So I think in terms of patient population, this trial is very similar to the large Cadena trial and a little bit different from the CASTLE-AF and the Camera MRI trials, which were predominantly low EF trials. So can you tell us about the major findings?
Yes. So the first thing that I'll bring up is is what I mentioned in the introduction about the rationale of the study was maintenance of sinus rhythm in the ablation arm. So as opposed to 50% of patients maintaining sinus rhythm in the AFFIRM study, it was 80% of patients were maintaining sinus rhythm at follow-up, and that's based on ECGs. So you know, not perfect, but at least gives you an idea, and that's how it was done in those trials way back when. It was ECGs at follow-up. So very comparable data there. In the rate control arm, of course, it was in 85 to 90%. So the primary outcome was death and heart failure events, just to remind you. And what we found was ablation-based rhythm control did not reach statistical significance over rate control in reduction of the composite endpoint of death and heart failure events. The hazard ratio was 0.71 and the p-value was 0.066. The confidence interval just crossed the line of unity. So we missed it just by minimal there. Now, when you look at the secondary outcomes, which included the Minnesota Living with Heart Failure questionnaire, AF quality of life using the AFFECT questionnaire, 6-minute walk distance, NT-proBNP, and change in ejection fraction from baseline, we met them all with statistical significance for catheter-based ablation. So the ablation-based rhythm control, I should say, they were all statistically significant. So if you compare that to some of the studies you mentioned, camera MRI, for example, and some of the ATAC and some of the other studies that have been done in this area, their primary endpoints were our secondary endpoints. So, so we reaffirmed what those studies found. Some of which actually, some of them were negative actually overall, but our study found a significant benefit for what that's worth. They were secondary outcomes.
I think all of these are very meaningful outcomes for our patients, because I know strictly from a scientific point of view, we tend to narrow down and focus just on the very, very hard outcomes like mortality. But I think equally important to the patient are these other things like quality of life, which we just discussed. Could you tell us and elaborate on the early termination of the trial? Like, what was the planned duration? What were the discussions behind early termination? Because that, I feel, is the burning question now.
Yes. So, the trial was initiated in 2011. It was terminated in 2018 due to a couple of issues. So the DSMB reviewed recruitment. Recruitment was going slowly at that time. That was one of the things that impacted their decision to stop the trial. The other decision was a lower than expected event rate at the time, and the perception that the study was futile based on the futility index, which was calculated at the time of 0.81, with the threshold for stopping the trial at 0.8. So it was just beyond futility. So at that time, the data that the DSMB looked at was based on 363 patients. And they had been followed for a median of 19.5 months. So you know that our final numbers were 411, so we did recruit more, but the data they had was based on a smaller part of the puzzle, a part of the trial. So the interesting part of that is the follow-up duration. So our final median follow-up for the study was 37.4 months. At the time, it was 19.5. And if you take a good look at the paper that is now online, the separation of the curves occurred just beyond 24 months, very similar to what you saw in the CASTLE-AF study. And so, when looking at it, and if you cut off the curves at 19.5 months, you aren't going to see that separation. And so, the DSMB made a decision based on the data that they had. They're there for a reason. We keep them there for a reason, to make sure that we're doing the right things for the patients. And their advice was to stop recruitment. So the intended enrollment was 600.
I see. So one of the very interesting results is one of your subgroup analysis showing the benefit in females.
Yes.
We examined previous trials. That's something new, and the thought is that females tend to be referred late for ablation. At that time, AF may be already advanced. They may have some more atrial myopathy. So I think this is one of the very important and striking results. Could you elaborate on the exact differences and try to basically educate us on why you think that subgroup benefited most?
Yeah. So the interaction p-value for that subgroup was just shy of significance. It was 0.077. So, in a study that was overall negative, it's a little challenging to know what to make of that result. It is interesting, however, and we haven't looked into the differences between the men and women yet. We will, of course, given this finding. But I'll hypothesize as to some of the reasons I think we may have seen that. I mean, obviously, it could be chance, right? So we have to keep that in mind. But some of the biological reasons and the underlying, mechanisms that may be driving the result is that, one of the things that we've observed about women with atrial fibrillation is that they are more symptomatic than men. They go to the emergency department more frequently. We looked at that in one of the recent cohort studies that we've done here in Canada. And, so there may be something about heart failure and AFib in women that is different from men. Maybe women have earlier onset of heart failure. So perhaps it is that they were earlier in their presentation in this trial, which did not require failure of antiarrhythmic drugs or even a trial of antiarrhythmic drugs to get into the study, which is different from some other studies that have looked at ablation. So that is possibly one of the reasons. And again, we have to look at the data to back this up. Women have smaller atria. Maybe they're more amenable to ablation. Maybe their response rate is different when they have heart failure. I mean, the number of events in women was very low in the ablation group. It was significantly different than the men. Less ischemic heart disease is another reason. Perhaps the driver for their heart failure was related more to the AFib than in men, where there may be other drivers for heart failure. So those are some of my initial thoughts. Again, we'll have to look at greater depth into the data to really understand why that existed and whether it was indeed real or not.
Okay. So what's the take-home message or summary for the non-electrophysiologists in our audience? What's the take-home message from this trial?
Yeah, that's a very, very important question. So the first take-home message is that in this trial of patients with atrial fibrillation and heart failure, we were not able to achieve statistical significance for ablation-based rhythm control in reducing heart failure and mortality with ablation-based rhythm control versus rate control. So that's number one. However, we did achieve fewer endpoints in the ablation-based rhythm control numerically. Had we extended follow-up or had more numbers, we may have been able to show significance. So I think we have to take the data from the trial and apply it to our patients. All of the secondary outcomes showed benefit. Quality of life, ejection fraction, these are not minor improvements. These are significant improvements that can affect mortality if we extended follow-up even. Those are the things that we have to keep in mind when we think about our heart failure patients. And the other thing that when you apply this trial to your patient population, in this trial, patients had to be eligible for either rate control or rhythm control. So they had to be okay to accept rate control. And so, patients who are highly symptomatic and are very ill with atrial fibrillation and heart failure may not have gotten into this study. And that speaks to the slow recruitment we had and the maybe potentially unwillingness to randomize patients like that into the trial. So, I think the data tells us that, maybe we're not there yet with ablation in reduction of mortality. Heart failure events, again, were less, but there may be some patients that do better, like high burden paroxysmal patients that are earlier in their substrate for atrial fibrillation. So those are the takeaway points, I think, for non-electrophysiologists.
Thank you so much. And, congratulations on running a very successful, large multi-center trial. That in itself is a huge accomplishment and a very important contribution to science. Thank you so much. And we will look forward to your subgroup analysis for based on gender. Thank you.
Thank you.